what are some of the exciting areas in GLP-1? First of all, we have now seen the completion of a phase 3 program of an oral GLP-1, and that's the first oral peptide in type 2 diabetes. So this is oral semaglutide. In addition, the phase 3 program for an implantable GLP-1 has completed. That's the ITCA, the ITCA mini osmotic pump with exenatide. So that's an implantable device with continuous delivery of GLP-1. We're also starting to see some phase 2 data of twin cretins, so looking at the combination of GLP-1 with GIP. And so there's a lot of excitement to see what GLP-1 can do with other hormones, the combination. What I'd be interested in seeing is if we could start seeing studies that look at earlier incorporation of GLP-1 compared to even earlier therapies, to see whether we can affect long-term outcomes, not just in those with established cardiovascular disease, but in the overall population that we see on a day-to-day basis.
It's been an exciting time in diabetes management, and the GLP-1 receptor agonists have, provided a lot of benefits that we've discussed, not only reducing cardiovascular risk, but promoting weight loss. That said, there's more to come. So there's a product called ITCA 650, which is exenatide, the same drug as the original GLP-1 receptor agonist, but instead of as a twice-a-day injection, packed into what's called a mini osmotic pump, so a titanium rod that has a very special membrane, and then a plunger that swells over time as tissue juice basically gets into the plunger. And as the plunger swells, it squirts out exenatide at a constant rate. The long-term aim is to have this as a 6-month, maybe one day even a 1-year implant, which I think would be a great thing for adherence, people not having to remember to take a drug twice a day or once a day or once a week, but literally going to the doctor and having this rod put in a very minor surgical procedure once every 6 months should be a game changer for many patients. And then the other real excitement is there's an oral formulation of the same drug, semaglutide, that's available today, that's being tested. It's co-formulated with something called SNAC, that the capsule is swallowed with a small glass of water first thing in the morning. Probably the best thing is for people just to swallow the capsule with a swallow of water and go back to bed or be still, because that SNAC enhances the absorption of the semaglutide, which is a protein, across the stomach lining. And the early clinical trials reports, largely through press releases to date, are incredibly promising. So this looks to be as effective an approach to glucose lowering and weight loss promotion as the injected semaglutide once a week as a once-a-day capsule. And for the small proportion of patients that just can't get over the idea of taking an injection, I think this will bring semaglutide to that additional segment of the population. So I think those are the major near-term developments. There are a number of other GLP-1 receptor agonists that are being developed, and I'm sure there'll be other approaches, including nasal delivery and other formulations that'll come in the future. I think the biggest challenge is getting patients with clinical cardiovascular disease on these drugs. So it's probably nearly a third of the population has clinical cardiovascular disease in the setting of type 2 diabetes, and the best evidence is that no more than 5 to 10% of them are using these very effective drugs.
It's never fun having type 2 diabetes. Let me just be clear about that. But in this day and age, we have so many tools at our disposal. We have so many better medications, several classes. We are now finding cardiovascular benefits in a diabetes medicine. If you had told experts that 25 years ago, they'd look like, at you like you were crazy. So we have these medications. We have to start using them routinely. We have to be advocates for our patients. And if that's an injectable, then so be it. It's an injectable. Let's find the best agents for our patients. Let's don't shrink away with cost as the only defense, when in fact a lot of these agents are affordable for a vast majority of our patients.